To both our lecture regulars and newcomers alike, welcome. Thank you for joining us. We don't know when we're going to be able to welcome you back to the museum in person, but we are planning to do more virtual programming like this. We're always looking for suggestions, so feel free to write us with suggestions or to sign up for a mailing list by writing to mghhistory@partners.org. For our lecture regulars, I think it's worth noting that many of the people who you saw in person over the past year have turned their attention to COVID. For example, superbug expert Matt McCarthy has been fighting on the front lines in New York City. Barry Tierney, who introduced our Fantastic Voyage movie night, got thrown into running an innovation center at Mass General Brigham. And our last in-person lecturer a few months ago, Joe Betancourt, the Chief Equity and Inclusion Officer here, has been sort of fighting to combat the racial and socioeconomic inequalities that have been laid bare by the pandemic. You're about to hear by another extraordinary group of people who have been working on the front lines. One housekeeping note I should mention is that we do have the question feature enabled tonight. We will have a few minutes at the end for questions if you want to submit one through that feature. So I'd like to turn things over to Suzanne Coven, who has practiced primary care internal medicine at Mass General for more than 20 years. She's also the writer in residence at Mass General. Some of you might remember her from the second annual Poetry at Work event that happened at the end of April. Her writing has appeared in a number of places, including the Boston Globe and the New England Journal of Medicine. So with that, I will turn it over to Suzanne.
Well, greetings, everyone, and thank you, Sarah, so much for hosting us just as warmly and graciously online as you always do in person, though we are going to miss the brownies. As Sarah mentioned, that I've been practicing at Mass General Primary Care for over 20 years. I am actually in a few weeks going to celebrate my 30th anniversary here. So 30 being considerably more than 20. In the last few years, I've had the great joy to have an additional role as writer in residence. And one of the things I do in that role is help mentor clinicians and other hospital staff interested in writing. I will be frank with you that when the pandemic started, I thought that part of my job would pretty much dry up. And the reason I thought that is that I thought that hospital workers would be too busy to write. And I also did wonder for myself and others whether writing one's personal stories, personal views, might feel like too small a lens in the face of such a global catastrophe. It turns out I was completely wrong about both of those things. Within a few days of the start of the pandemic, in the second week of March, my inbox was filling with manuscripts, and it hasn't stopped. Most gratifying for me has been to see the writing that has been done by our house staff in national outlets, as you'll hear. We've heard a lot about workers on the front lines, but of course, everyone in medicine knows that when you speak about a resident being a frontline worker in the pandemic, it's a bit of a redundancy. Residents are always on the front lines, pandemic or not. It really, the people you are going to hear read and talk about their writing tonight are extraordinary clinicians and extraordinary writers, and what they have been able to do with their writing under just extreme time pressure, emotional pressure, physical exhaustion is, to me, awe-inspiring. And I will say that at this time of great discouragement, nothing buoys my spirits as much as the work that I've done alongside my younger colleagues. One of those younger colleagues is my co-host tonight, Vinayak Venkataraman. Is a fine writer himself. He's a rising fourth-year medicine pediatrics resident here at Mass General. He's a graduate of Duke's Medical School. And he's also someone who has a great commitment to bringing medical humanities to his resident peers. He serves as a resident leader in the Department of Medicine Sports Initiative, which brings activities and other resources to house staff with the goal of increasing compassionate care, not only for our patients, but in the lives of the residents. So with that, I'd like to ask Vinayak to say a few words about the special role that residents have played during this most extraordinary time. Vinayak.
Thanks, Suzanne. I just wanted to share a few words, as Suzanne mentioned, about the resident experience at Mass General and sort of collectively across the country. When I've needed strength these past few months, I've often looked to the house staff of Mass General Hospital. Our collective response has inspired. Battling COVID has left us with indelible wounds, but also with renewed purpose and connection. We didn't ask for this, but we didn't shy away. We stepped up. We were called to serve in different roles and came together with unified objective. Many non-internists and non-intensivists became both overnight. New floors and units were created each day. Residents and nurses who had never met worked together side by side. As an example, I led a team of pediatric interns and worked with pediatric nurses as we cared for sick adult patients. I've worked on a surge ICU team composed of pulmonology attendings, cardiology fellows, medicine residents, surgical ICU nurses and respiratory therapists, and neurology floor nurses and physical therapists. I feel like I know the whole hospital now. We felt joy as we've seen some slowly recover and go back home. We've also felt sadness and isolation in unprecedented amounts. We've called families who suffer from afar, unable to see their loved ones in the flesh until their last breaths. We've explained complex decisions such as resuscitation, intubation, and tracheostomy, and comfort measures by phone. We've viscerally witnessed devastating and intractable injustices and inequities as vibrant, diverse communities were hit hardest. We sometimes have cared for entire families on the same unit. We've gone to work fearing for our safety, the safety of our colleagues, and the health and wellness of our friends and families at home. Despite all we have seen and all we have worked, we've refused to become desensitized. We've worked together to maintain our collective humanism. We've kept each other afloat and pushed each other forward. Though we are returning to new normalcy, I have no doubt the house staff of Mass General will weather this storm together. I am so excited for all of us to hear their stories tonight. And first, I'd like to introduce our first speaker, Pooja Yeramili. Pooja Yeramili is a rising senior medical resident at Mass General Hospital in the Global Medicine Program. She's a graduate of Yale, the London School of Hygiene and Tropical Medicine and of Economics, and the Perelman School of Medicine at the University of Pennsylvania. She has served as a project coordinator for the Young Professionals Chronic Disease Network, a consultant for the World Health Organization, and a research assistant at the Harvard Global Equity Initiative. She has worked in South Africa and India, studying the challenges associated with tuberculosis, aging populations, cancer care and control, and access to medicines and vaccines. She also is an avid writer and a true lover of writing. She will share a piece now on the complex fears and emotions facing COVID as a resident provider. Pooja.
Thanks, Vinayak. So firstly, thank you all for having me here today. I guess I'll just jump into kind of my writing process and how I've been involved over the years. So I've been lucky to have several opportunities to publish my writing sort of since before medical school, but primarily what I focused on was writing op-eds, and I published those op-eds in a variety of informal, formal venues ranging from sort of PLOS blogs to Huffington Post to Stat News. But I also sort of wrote some more reflective pieces that I mostly kept for myself or shared with a smaller group of individuals like friends or family, because I viewed writing as a way to process emotions of challenging or sort of poignant moments. And kind of as Vinayak was highlighting, the coronavirus pandemic has given us a lot of challenging and poignant moments. And so I found myself writing even more. And just to give a little bit of context to the piece that I'll read a little bit from, I wrote it sort of in the early weeks of March when we were first starting to worry about coronavirus and what it would mean in the hospital. I had actually just arrived back in Boston from being abroad for quite some time and hearing about how different health systems were worried about tackling this virus. And I immediately came back to working in the ICUs, the oncology floors, the emergency department, and it was really jarring to me to kind of see this nervous energy that was building in the hospital as if we were readying ourselves for some sort of battle, emphasizing phrases like this is our time to step up and this is our moment. And we were starting to hear hero worship of frontline workers and hearing things like we're getting ready to go to war and things like that. And for me, especially in those initial days when we were starting to hear about it, it was all very hard to process. I didn't really see that kind of glory element that sort of language was evoking. I was mostly kind of grappling with the sadness and the burdens that the pandemic might bring. So I wrote this reflection around that time and ended up publishing it in Kevin MD around the end of March 26th. So I'll read from the beginning of the piece now. Okay. Upon walking through the revolving door that guards the hospital's main entrance, I was ushered by security staff to join the queues of my peers, also seeking passage to their respective posts. The new policy, the officer explained, examining my hospital ID to confirm that I am, indeed, an employee. Visitors are no longer allowed. Please sanitize your hand, another instructed me as he pointed to the neat rows of surgical masks lining the sterile white table next to him. 1 per employee per day. The halls of the hospital were always bustling with the chatter of patients, their families and friends, and healthcare workers. But today, the silence was interrupted only by the footsteps of my fellow hospital staff scurrying off to work. I pushed open the double doors to the emergency department, expecting to be greeted by its usual chaos. But no, even there lay a strange order. Physicians, nurses, and physician assistants, all uniformed in blue scrubs, hairnets, goggles, and face masks, marched steadily, marking every other patient room with precaution signs. While the floors above us experienced the calm before the storm, we were seeing it on the horizon. A grandparent from a senior home testing positive for COVID-19. A mid-30-year-old, the primary caregiver to her elderly parents, suspected to have the disease. This is only the beginning. Don't touch your mask was my mantra that day. There were no masks to spare, none to be found in the supply bins, none in the closets. Protective equipment was a scarce commodity, one to be rationed, 1 per employee per day. And so, without eating or drinking even a sip of water, without scratching our noses or rubbing our tired eyes for fear of contamination, we proceeded, room by room, to evaluate our patients. And as we walked into each room, we carried uncertainty. We could not always predict who would reveal to us that they did, in fact, have symptoms of COVID-19. But we did not have enough protective gear to always don gowns, just in case. But I also carried the constant worry that I, an otherwise young and healthy physician, the perfect setup for an asymptomatic carrier, could be spreading the disease to the very people I was trying to protect. But we did not have enough capacity to test everyone. So just to pause for a little bit and talk about this, at the very beginning of our sort of pandemic response, we didn't really have standardized protocols. The protocols were changing pretty much every day, sometimes separately in different departments. So in the ED, and I believe at the same time on the floors as well, we didn't wear N95s unless there was a clearly aerosolizing procedure like a nasopharyngeal swab or intubation. We didn't even really wear surgical masks or gowns for every patient, only if their chief complaint was clearly like fever, cough, or shortness of breath. But oftentimes, as I'm sure many of the viewers of this are aware, you only find out that patients have those symptoms after you interview them without PPE. So in those moments, it was really hard to sort of feel like I was a normal human being, not some brave warrior or soldier as the media and some of my colleagues were evoking. But on top of that, there was also this worry that maybe I was inadvertently some sort of villain accidentally spreading the virus without PPE to some of these patients we were seeing. You know, you could see in the room next door an immunosuppressed cancer patient or an elderly patient with COPD. So I really did not feel like this hero that everyone was kind of making us out to be at all. So I'll just briefly go to the end of the piece. The rhetoric is that we are heroes, that we are privileged to have the skills to be able to help in this fight against an invisible enemy, that our patients are counting on us. But while some of my peers are itching for their moment on the front lines, I don't feel like a hero at all. After all, can heroes be afraid of what has come, of what has yet to come? What a burden it is to be called a hero when you never signed up to fight in a war, but know that it is your duty to. What a burden it is to foresee the tears of our patients and their families as they confront their suffering. What a burden it is to feel that you could be doing more harm than good on the front lines without protective equipment, a potential vector of disease. No, I reject the word hero, and I reject the war analogies, because they scare me. After all, I'm just a physician in training, a normal human being who can and must show up to work, not because I'm a brave adventurer waiting to defeat our assailant, but because it is my job and my ethical and moral responsibility to do so. So just to close out, I honestly didn't really know what to expect from this piece. As I mentioned, I'm not really used to publishing narratives, and I actually submitted it to a bunch of different places where I normally published op-eds, and it did get rejected, and I ended up publishing it in Kevin MD. And I was surprised to hear how it resonated with a lot of my friends in medical school and residency, but also a lot of other trainees and people who are working on the front lines. It seems like it was shared pretty widely for that reason. And honestly, for me, that was really comforting to kind of know that I wasn't the only person who was experiencing these kinds of qualms and fears. And yeah, so I found this process very sort of therapeutic and helpful for me. So I'll pass it back over to Vinay to continue the program.
Thank you. Oh, sorry about that, Vinay. Thank you so much, Pooja, and for your beautiful words. And you're quite right. Kevin MD is a great outlet for clinician writers out there. It touches a lot of people, particularly our peers. And it's an outlet I recommend a lot. And I've published there myself a lot, and really enjoy sort of entering the conversation that it engenders. Our next speaker is Alessandra Clayani. Alessa is graduate of Johns Hopkins School of Medicine, and she has just finished up her chief year of her ENT residency here at Mass General, and is continuing her surgical training at Vanderbilt. Alessa is a beautiful lyrical writer. Her essays in the New England Journal are just poetry, and she has also written for the New York Times and the New Yorker, and she is very brave in engaging dilemmas and controversies that other writers might not engage. And I think she's going to share with us one of those this evening. Alessa.
So thank you so much for having me. It's a real honor to be included in this group, and thank you for that lovely introduction. I'm going to save it for a rainy day. So I have been kind of writing in some form or another since I was a kid. Took a lot of kind of creative writing courses in college and in high school, and then was a little bit of a late bloomer in terms of coming to medicine. But once I started medical school, I realized that creative nonfiction was really more interesting than any of the fiction or like plays or poetry that I had written in the past, because these ethical issues that were coming up, or issues of kind of socialization and hierarchy and just all the things that you kind of start to encounter in medical school in a very real way, I found, like Pooja, I was able to process them much better and slower in writing. And so I wrote a lot during medical school, and then in residency, I kind of took a break, mostly because intern year and PGY2 year were extremely busy, and I just kind of journaled and saved things for later when I had time to process them, and have been lucky to publish some pieces, mostly kind of reflective or ethically tinged essays in the last couple of years. So the piece that I am going to read from was published on April 22nd in the New Yorker. And it really stemmed from, so I'm in otolaryngology, head and neck surgery resident, going into head and neck surgical oncology. And our area of surgery is it was considered to be somewhat dangerous, just because we were like in people's oral cavities and nasopharynxes, and every procedure that we do, including just examining patients, is aerosol generating. So coronavirus really, while we weren't kind of on the front lines of taking care of patients in the COVID ICUs or the medical wards, it really upended our residency in a way that I'd never anticipated could happen. And so this piece came out of one of my weeks being the chief of all inpatient otolaryngology services at Mass Eye and Ear and Mass General, and seeing consults and kind of seeing in a way that that coronavirus had changed everything. So I'll read from the beginning of that piece now. A few weeks before the coronavirus hit the eastern seaboard, a lifetime ago, in other words, my partner's cousin noticed a lump in her breast. Her mother had survived breast cancer, so the next few steps were no surprise. Consultation, biopsy, and when the biopsy confirmed cancer, rearrangement of her calendar in order to schedule a lumpectomy. A chef by training, she took all these preliminary steps with calm efficiency, as though assembling a mise en place. All that remained was to actually have the surgery. It was to happen on a Monday at my hospital in Boston with an exacting breast surgeon I'd scrubbed with as an intern. Then the virus hit, her surgery was deemed elective, and we got a terse update from her husband via text message. Surgery delayed a few months, estrogen therapy. As soon as the word pandemic made it into national parlance in March, surgeons at my hospital were asked to postpone non-urgent visits, convert to virtual visits when possible, and cancel all elective surgeries. These measures had several goals: to minimize contact between people under stay-at-home orders, to free up space in the healthcare system for an expected surge of critically ill coronavirus patients, and to reduce use of personal protective equipment, or PPE. Any surgery would by necessity use up masks and eye shields, and also temporarily take up an operating room ventilator, which physicians might need when the surge hit. Surgery had to be carefully considered and, if possible, deferred. In medical terms, elective doesn't mean unnecessary, but rather implies that the surgery can be safely delayed without major medical consequences to the patient. In my specialty, I'm in my final year of residency in ear, nose, and throat surgery. Many procedures are unequivocally elective. Nobody argues that facelifts or hearing implants are anything but elective. Emergencies such as hemorrhage, airway obstruction, or ear infections that spread to the brain and cause meningitis are also easy to define as emergent. But urgent surgeries, which are neither elective nor emergencies, but which are permissible under the COVID-19 restrictions, are a gray area. At the hospitals where I work, defining them has so far been left up to individual surgeons. So the rest of the piece kind of goes on to describe a few kind of anecdotes about what happened during that week that I was on, or during the several weeks that I was on call. So all of the cases from the weeks were just diminishing over the course of the weeks. Like every case was canceled after we realized that we didn't have enough N95 respirators for everybody to wear them in the operating room. And because we didn't have enough preoperative testing at that point, we were potentially endangering entire roomfuls of operating room staff and surgeons. And that was just a very odd feeling, to be kind of busy but not busy, and watching these hierarchies that I have been very intently watching and observing for several years of residency just sort of disappear overnight. So I'll finish with the kind of ending of the piece, and I'll just go into it. Although the numbers of cases, consults, and inpatients were lower than what I was used to during my last week on service in March, every decision that I made was fraught and required at least double or triple the amount of time I normally need to think it through. By the end of the week, some cases had been rescheduled after patients underwent COVID testing, and in the operating room, I was at once soothed by the partial return to normalcy and anxious because of it, knowing that the recommended PPE for airway surgery was changing every day. That week, I saw a consult for a patient who had come to the hospital coughing up blood. The bleeding had required a transfusion, but had since slowed. Later, the patient was found to be COVID-19 positive, and at some point, someone looked in his mouth and noted a tumor on the back of his tongue, likely a cancer, almost certainly the cause of his bleeding. His COVID-19 symptoms were worsening. My team was asked to figure out what to do next about the tumor. In normal times, how to treat him would have been obvious. The attending on call and I would take the patient to the operating room, biopsy the tumor, and do what is called a direct laryngoscopy to survey the remainder of the patient's mouth, throat, and voice box for other cancers. But this situation was different. Would it be ethical to expose the entire operating room staff to an aerosol-generating biopsy when the patient had stopped bleeding, seemed to be in no imminent risk from his tumor, and was COVID-19 positive with worsening symptoms? On the other hand, given that the bleeding was so extensive that it had required a transfusion, should the case count as emergent? I spoke with my attendings and several other doctors caring for him, and together we came up with a plan. If the patient's tumor started to hemorrhage, forcing our hand, we would intubate him, pack his mouth with gauze to stanch the bleeding, and take him to the operating room for biopsy and cautery. But if he didn't have bleeding requiring intervention, and if he survived COVID-19, we would take him to the operating room for a biopsy when he cleared his viral infection. Every day I check his chart and wonder whether we're doing the right thing. At times it feels like we found the only logical response to this problem. Other times it feels like stalling. Like our patients were in a holding pattern. The chef takes her hormone therapy, the case board stays mostly empty, and my patient with the tongue tumor remains hospitalized. For now, we wait. So I was very lucky in that I've never pitched to the New Yorker before, and I pitched them this piece and they took it, which I presume is not going to be my experience with the New Yorker ever again, or really any other publication. Like I've had many, many publications rejected on many, many occasions, but this was like the one. So that was great. And then as far as reception to the piece, people have been very kind about it. The fact-checking process with the New Yorker was insane. So like they called every single one of my attendings, none of whom are named in this piece, and were like, hey, did you say this? And luckily they all said yes, because I told the truth. But it was a really interesting process, and people were very kind with the reception. So I will turn it back over and thank you guys for having me.
Awesome. Thanks so much. Our next speaker is going to be Clayton Dalton. Clayton was born in Houston, studied history at the University of Texas and medicine at Columbia University College of Physicians and Surgeons. He trained in emergency medicine at Mass General and Brigham and Women's. He's interested in writing, in his words, about all aspects of the natural world, both within the body and without, and that are strange and wonderful. A prolific writer and journalist, Clay has written for a host of publications, including The New Yorker, The Guardian, Scientific America, NPR, and WBUR. He will be sharing a piece for the medical dispatch section of The New Yorker on the early experiences of caring for COVID patients in Boston.
Hi, my name is Clay Dalton. I'm an emergency medicine resident in my fourth year of training at Mass General and Brigham and Women's Hospital. I'm excited to share a little bit with you today about some running I've been fortunate to do in the past few years, specifically some running I've done in the context of COVID with the New Yorker. I started writing about 4 years ago. My first published work was with NPR when I was an intern, and I've since done pretty regular work with NPR, and then I published in a variety of other magazines as well. And then in the time of COVID, I've been really fortunate to do some work with the New Yorker with a series of dispatches from the ER. The idea of a dispatch is basically just to try and bring readers into the hospital or into the emergency room and to describe what it's like to be there in this very strange time. And so my approach to that was just to be aware of what I was noticing while I was at work, and to keep notes about things that struck me that were strange or unusual, or could paint a more vivid picture of what it was like to be taking care of patients in the hospital in the time of COVID. And I'll read a short selection from a piece that was published on the 2nd of April with the New Yorker, just describing what it was like in the sort of first few weeks of the pandemic here in Boston. So this would have been late March, as things were starting to pick up, but we weren't seeing near the same level of acuity and volume that hospitals in New York were seeing, and we were wondering if we were going to be next in the weeks ahead, or if social distancing would protect us to some degree and protect our patients. So I'm going to just read a selection here from the piece. The virus has changed how we think, feel, and interact. My colleagues and I all seem to be paying more attention to our own bodies. We wonder if our headaches are a symptom of COVID or just allergies, or if we're starting to develop sore throats. Recently, I noticed that I now grip door handles with just 2 or 3 fingers. With everyone wearing masks, it's become more difficult to pick up on emotions and moods. As compensation, I've registered, sometimes for the first time, the eye colors of people with whom I've worked for years. I find it hard not to feel superstitious. There's a playground near my house, now closed with a padlock and chains. The magnolias and forsythia planted there have taken advantage of the mild weather and are now sprouting buds. The forsythia in particular have seemed portentous. Their blazing yellow flowers are a symbol of spring. In Chinese herbal medicine, they're a tonic for fever, sore throat, and cough. Last week, it was snowing as I left the hospital. I caught myself worrying about the forsythia and wondering what lies ahead. In the last few days, palliative care doctors who specialize in decision-making and well-being at the end of a patient's life have started joining us in the ER. Before the sickest patients are intubated, these specialists, wearing full PPE, enter their rooms to discuss the options. Because it can take more than a day for results from a COVID test to arrive, patients may find themselves contemplating intubation without knowing for sure that they have the virus. If they do have it, prognosis can be grim. If they turn out to be suffering from some non-COVID disease, ordinary pneumonia or heart failure, they may be more likely to recover. Some patients choose not to be intubated. Others decide that they do want to move forward, but determine in advance that if their COVID tests come back positive, they will undergo a terminal extubation in the ICU. Some conclude courageously that they'd rather free up the ventilator for other, younger patients, a form of self-triage. This was a strange time for us in the ER. We are so used to being so well-resourced, having everything that we need, having enough ventilators, having enough equipment, having enough ICU beds. It's very strange for us, and I know it was strange for physicians elsewhere in the country and around the world to have to think about perhaps rationing these sorts of resources or trying to determine who would benefit more. It's a very uncomfortable calculation and calculus that we as physicians are not used to making. And we're fortunate now to be some months beyond where we were when I wrote this piece. And we never came to the point where we ran out of these things. But we came close, and it was just a very surreal and strange and difficult thing to consider. I'll read the concluding paragraphs of this piece as well now. Patients are scared too, of course. I'm seeing far more fear in their faces than I'm used to, especially those who are elderly or have many comorbidities. They know that the hospital has become a dangerous place for them, even if there's nowhere else to go. For now, we have the time to talk with them, acknowledging their fears and offering some reassurance. As the number of patients surges, time at the bedside will become another scarce resource. I sometimes find myself addressing, in my mind, those future patients. Please know that you are still safe in our hands, and we will care for you to the best of our abilities, even if we have just a few moments to spend with you before moving on. On Friday in Rome, Pope Francis conducted a remarkable prayer service as rain fell on an empty St. Peter's Square. He had noticed everywhere the fear that I had seen in our patients. For weeks now, it has been evening, he said. Thick darkness has gathered over our squares, our streets, and our cities. It has taken over our lives. We feel it in the air. We notice it in people's gestures. Now, he said, it was the time to reawaken and put into practice that solidarity and hope capable of giving strength and meaning to these hours when everything seems to be floundering. In and out of the hospital, people seem to be seeking that strength and meaning. A friend of our family's has begun retooling his company's 3D printers to produce masks. Another friend is making face shields from scratch in her living room. My mother is donating blood and marshaling her friends to sew fabric masks. Boxes of N95 respirators are appearing on our hospital doorstep. I find myself thinking of the Pope's speech. Lord, give health to our bodies and comfort to our hearts, he said in prayer. You ask us not to be afraid. Tell us again, do not be afraid. So now we're several months further along into the pandemic than where we were when I wrote this piece. And it has certainly been challenging. We've been fortunate that it hasn't been, for us in Boston, as frightening as what many of our friends and colleagues went through in New York and in other places around the country and around the world. We are all wondering what will happen when we start to reopen things and if there will be another wave of sick patients in the next few months. But if there are, then we're hopeful that we've learned a lot about how to take care of these patients and that we will be able to make sure that we have the resources to do so if we have to do it again. Thank you for having me, and have a wonderful day.
Thank you, Clay. As you saw, that was a pre-recorded presentation because Clay is on duty this evening. So next, we're going to hear from Jack Turbin. Jack's a graduate of Yale School of Medicine and has just completed our pediatric residency and is moving on to Stanford for fellowship training in pediatric psychiatry. A few years ago, I first heard about Jack when one of his medical school mentors at Yale emailed me to say that he would be coming to Mass General to be an intern, and he was interested in writing, and might I look out for him? Well, I Googled him, and he had already published a beautiful op-ed in the New York Times about physicians evolving a concept of how to best care for transgender children. And this is a great area of interest for Jack clinically and in terms of advocacy. And so starting out from the gates, he was really doing pretty well. And he has throughout residency been incredibly prolific, writing for the New York Times, and GQ, Vogue, Vice, Vox, and my favorite piece of his, which is residency training out of the closet in the New England Journal of Medicine, one of the most beautiful pieces ever sent to me, I think, by a resident about his experience of medical training, both very personal, but also incredibly resonant and really globally important. So with that, Jack.
Thank you. You just made me blush so much that I don't know if I can read anything now. So I actually came down with COVID-19 pretty early on in the pandemic. Before we realized that young people could get really sick from it. And I ended up being out of work for about a month. So I was at home and had a lot of time to write. And I ended up writing this piece for Vox about convalescent plasma transfusions, which are an experimental treatment for coronavirus, and how some rules at the FDA make it so that gay and bisexual men can't donate blood to help with this experimental treatment. So I'll start by reading from the beginning. A few weeks ago, I came down with a mild cough and runny nose, and I heard that seasonal allergies were starting early and didn't really think very much of it. The next day, I woke up and I was exhausted and had a splitting headache. And as a doctor, I had to get tested for COVID-19 before I could go back to work in the emergency room. And so I got tested and the result was positive. Fortunately, I'm already back to feeling like myself, and I was one of the lucky people with relatively mild symptoms who recovered quickly. And now that I'm well, my blood could be used as an experimental cure for the new coronavirus. But because of homophobia, that won't happen. And I'll summarize the rest of the piece. The experimental treatment that I'm talking about is this convalescent plasma transfusion treatment. And what that is that people who have recovered from coronavirus, their blood has antibodies that attack the virus. So if you take the blood from someone who's recovered and transfuse it into someone who's dying from the virus, those antibodies may be able to help fight the virus for them so they can recover more quickly. But unfortunately, there's this FDA policy that makes it so that people like me who are gay cannot donate blood. So in 1985, during the AIDS epidemic, the FDA placed a lifetime ban on blood donations from any men who have ever had sex with men. At the time, they wanted to make sure that there wasn't undetected HIV that was getting into the blood supply and then being transfused into patients who would then contract the virus, which at the time was kind of uniformly deadly. But now things have changed a lot. So the testing of the blood supply has really improved, and currently the risk of contracting HIV from a blood transfusion is around 1 in 1.5 million. But the FDA rules haven't changed very much. There's still kind of this idea that being gay or bisexual is this huge risk factor for having undetected HIV, even though that's not true. So the real risk factors for having undetected HIV are things like having multiple sexual partners or not using condoms. But the FDA doesn't screen for those things. The FDA just screens for the sex or gender of the person that you're having sex with. And it doesn't make sense, right? So why should a monogamous gay man who's only had sex with his husband be banned from donating blood, whereas a heterosexual man who's had condomless sex with 100 female partners in the last 3 months can donate blood, when that latter person is at a much higher risk of having undetected HIV, which would make it into the bloodstream. Under the Obama administration, they did improve this rule slightly. It went from a lifetime ban to a 12-month abstinence requirement. Not surprisingly, there wasn't a huge surge of people signing up to be abstinent for a year to donate blood. So under the Trump administration, they shortened the ban to a 3-month abstinence requirement. And in the piece, I talk about how that's not good enough. What the FDA should do is what some other countries have done, like Spain and South Africa and several countries in South America, where they've changed the screening procedures. So instead they ask about, do you use condoms? How many sexual partners have you had in the last month? People have also talked about asking people if they are on HIV pre-exposure prophylaxis, a medication that dramatically lowers your risk of contracting HIV, even if you are having unprotected sex. But the FDA hasn't done that. They still have this unscientific ban just on anyone who's had either a man who's had sex with a man or a woman who's had sex with a man who's had sex with a man. So the one problem is that this just isn't scientific, but also it really takes a psychological toll on gay and bisexual men. It promotes this internalized homophobia that many gay men experience from growing up in a homophobic society, that you can only be good and pure if you don't have gay sex. And this ban is kind of saying the same thing, right? The only way you can be a good charitable person, the kind of person who donates blood to help people, is if you don't act on being gay or bisexual. So I'll jump to the end of the piece. Plasma donations are critical. If this experimental treatment works, countless deaths from COVID-19 could be prevented. But in addition to the plasma, the US also has a dire shortage of whole blood. Due to social distancing, there have been 150,000 fewer blood donations since the pandemic began. More blood is, for the first time, leaving blood banks than is coming in. And this blood is desperately needed for trauma victims who are bleeding out, cancer patients who are undergoing chemotherapy, and children, for instance, with sickle cell disease, just to name a few of the groups who desperately need this. Federal officials have been out begging the public to donate blood, but they should know that gay men like me are ready to roll up our sleeves and help. America is in the midst of a public health crisis. Old homophobic policies are making it worse, leaving trauma victims without donor blood and withholding plasma donations that potentially save people dying from the coronavirus. It's time for the FDA to lift the ban and save lives. And when they do, I'll be the first in line. And this piece generated a lot of attention. I ended up going on The Daily Show with Trevor Noah to talk about this, and just did a video with the Washington Post that just went up. So I'm really glad that the media is paying attention to this and getting the word out, because a lot of people don't know about this policy. And hopefully there will be more and more pressure on the FDA to move towards something that is less homophobic, less psychologically damaging, and something that in the end is going to help everyone by having more blood donations for the blood supply.
Thanks so much, Jack. Our next speaker is Chase Anderson. Chase is an adult psychiatry resident at Mass General Hospital and McLean Hospital. He was born in Woodland Hills, California, and then moved to Seattle, Washington at 12. He completed his undergraduate education in chemistry and master's in biologic engineering at MIT. And he is also a graduate of the Northwestern Feinberg School of Medicine, and will soon be starting his psychiatry fellowship at UCSF. In his free time, he enjoys going for long walks around Boston, listening to K-pop, reading fantasy books, playing soccer, writing, and planning dinners with friends. He'll be sharing a piece on the unique experience of being a psychiatrist redeployed to care for COVID patients.
Thank you for that introduction, and it's really an honor to be here with all of you. So this piece came out of, actually, Jack and I worked on it together. And back in the day, I had an anonymous Twitter account, and I had seen a lot of people that were very nervous about psychiatry residents maybe being redeployed, or dermatologists. And a lot of people were forgetting that all of us had gone through training and we were all physicians. And especially around psychiatry, we saw people saying, like, what is a psychiatrist going to offer? And so on our little anonymous Twitter, I was able to speak to that. Jack then had been asking me for 3 years to write with him, or to write in general. And I was like, oh, fine, I'll give in. Like, we'll do this. And he actually said, why don't we turn this into a piece? And I felt very fortunate that somebody like Jack wanted to work together and saw something in the way I wrote. So thank you, Jack, again for that. And this is one of the first pieces that I ever published. My other one is under my pseudonym, Casey Ardham, and that was about bigotry in medicine. I have since dropped that pseudonym, but those two pieces came out around the same time, and those were in the past month or so. And so this piece stemmed from that little Twitter thing that we did as a thread to help people feel a little bit more comfortable with psychiatrists actually taking care of you. And what I have been writing about since then has been, I shifted a little bit to talk about race as well as diversity. And then George Floyd happened. So I've been really ramping up talking about that a little bit more, as well as what is racism and homophobia like inside of the hospital system, as well as America. So I used to write fantasy, but I have changed gears a little bit. I will share the first part of our piece. As the numbers of Americans with COVID-19 rapidly rises, doctors are among them, having no special immunity to the virus. They are being quarantined in large numbers, leaving hospitals short of staff to care for the influx of COVID-19 patients. In response, these facilities have started redeploying specialists like ophthalmologists, dermatologists, and even psychiatry residents like us to treat patients on coronavirus floors. Sure, we've heard the mocking memes like, don't go outside unless you want a psychiatrist treating your pneumonia. We're accustomed to people thinking psychiatrists aren't real doctors. We're usually okay with the jokes, but not now. During the pandemic, they are creating unnecessary fear. We believe that if you are afflicted with COVID-19 and have a psychiatry resident as your doctor, there's no need to panic. In fact, there may even be some important benefits. Psychiatrists are physicians, which means that they went to medical school and passed the United States Medical Licensing Examination, a test of general medical knowledge required to start residency. All new doctors, including psychiatrists, have similar training in the first year of residency, also known as internship. This year involves working on units nearly identical to coronavirus units. As interns, psychiatry residents treat conditions ranging from pneumonia to heart attacks. Most also work in intensive care units, taking care of the hospital's most critically ill patients. So we did that piece and then went on from there to talk a little bit more about what psychiatry can provide. We wanted to allay a lot of concerns that people were having about psychiatrists maybe not having the proper training and talked about how we're supervised and things like that, as well as one of the things that we did discuss too is how psychiatry residents, we do consults where we have to know medical information as well as psychiatry information. And so we provide a little bit more help in some ways with not only helping team dynamics, but also speaking to the fact that we can help with things like ICU delirium and intubation and post-traumatic stress disorder that is being seen in residents as well as with patients. So the piece actually got rejected a bunch of times, and we had sent it to Stat News, I think, pretty early on and hadn't heard anything back, so we had moved on. And Jack and I were like, who do we send it to next? And the person who we'd sent it to at Stat News actually reached out to us after all these other rejections and said, oh, this got lost in my outbox. Would you still like to have it as part of Stat News? And we were like, oh yeah, absolutely. And he was like, oh, has it gone anywhere else? And we're like, no, just, we were just wondering if you would maybe still take it. So he took the piece and edited it, and felt very fortunate that this is one of my starting pieces to help launch my career in a lot of ways. And so I'm going to read the ending of it. It goes without saying, but psychiatrists also have expertise in helping patients and families deal with the depression, anxiety, and grief that often accompany serious medical illness. Mental health issues are so common among people who are ill that psychiatrists are often called upon to provide consultations in the hospital. At the hospital where we both work, psychiatry consults are placed for 1 in 5 patients. We agree with the opening sentiment of the anti-psychiatry memes floating around. People should stay at home to prevent the spread of coronavirus. But if you catch the infection and find yourself in the hospital with a redeployed psychiatry resident as your doctor, you'll get excellent care. So the piece was widely shared and felt really privileged to be a part of that. And people at McLean were reaching out to us, as well as other people from different hospitals, as well as my dad, who's a physician, of course, then went and read it and commented on it, which was very cute to see. And I was like, thanks, Dad. So I think like it was a nice piece to talk about coronavirus, but also talk about us being psychiatrists during that time. And then again, it was really what helped launch like my career as well. And so I will always feel very fortunate for being a part of this piece with Jack. So thank you.
Thank you so much, Chase, and thank you, Jack and Clay and Alessa and Pooja. And I also don't want to forget to thank our host, the Russell Museum, Sarah Alger and Tegan Kehoe, who's with us this evening, and our technical director, Bo Toof. Before we take questions, I hope there are a few popping up. I just want to observe how interesting it is that you are all residents and all writing about COVID and yet wrote completely different pieces. And, you know, so if anybody out there is worrying that, you know, there's nothing new left to write, it turns out that's not true. The other themes I'm hearing, and I'm glad to hear, is that there's a lot of rejection in writing, and the prize goes to the persistent and the stubborn. And then finally, I just love to hear about collaborations such as we heard between Jack and Chase, which of course mirrors the kind of collaboration we see clinically in the house staff. Sarah, you can tell us if there are any questions. I have a question, which is, you know, way back in prehistoric times, February, you were sort of thinking about your clinical career ahead of you and your writing career ahead of you. And then this big rock landed in the middle of all of that. And I wonder how it's changed your, let's say your writing career plans, or your perspective on what writing can do, especially when done by a clinician. Anyone? Chase, you've got the floor.
All right, thank you. So I think again, this was the piece that helped launch my writing in a lot of ways. And I think it was really cool to see how Jack and I could work together on this. And I think I'm going to twist the question a little bit, because what actually changed for me was George Floyd being murdered. And so then my writing changed, and I thought it was maybe time to start sharing what racism actually feels like in a lot of ways, and how that impacts people on a daily basis, as well as homophobia and things like that. One thing I'd also realized was that in a lot of ways, my writing and doing advocacy work had been inside of my hospital system. Coronavirus, as well as racism in America and how we've been reacting to it, taught me that maybe it was a little bit of time to step onto a more national stage, and maybe put myself at a little bit more risk by opening myself up in a lot of ways and sharing those experiences. So I think both of those came at, like, I don't want to say the perfect time, because they both were horrible, but I think it actually, both of them really informed that it was time to maybe reach out and write pieces that would help people who felt maybe a little bit alone, or they felt as though they were going through a lot of issues at their medical school and didn't have somebody who could resonate with them at the time. So that's how my writing changed a little bit.
Wonderful. I love the idea of the impulse to, well, we've heard a lot about staying in our lane as clinicians, and the impulse to recognize how large our lane actually is. Other comments from our writers about this? How did all of this change your writing plans or your clinical plans or perspective? Now, yes, Vinayak. I know none of you are at a loss for words, so speak right.
I go first, right? I think it was actually I think well timed within residency, at least for me. I think being at Mass General, it's a large academic tertiary care center with a lot of like high price specialties and like really fancy technology and labs and imaging. And sometimes as a resident who's focused more on the general practice, it's you sort of feel like the small cog in this like larger machine. But I think with COVID, it sort of reminded us of the power of general medicine, because all we were really doing was, just general medicine as it's been practiced for decades or centuries, really. Support the body through a stress, meet it where it's at, give it what it needs, and as it hopefully recovers from the stress, come down on your support. And on the flip side, unfortunately, if the body's not responding and getting worse, having those difficult conversations with families. And I think this was an opportunity as a resident to like really showcase like what the power of general medicine and general practice is. And you don't need fancy labs or imaging or tests to provide care for COVID patients. You just need compassion, humanity, and just good common sense.
It's a great observation. Osler said, "He who knows syphilis knows all of medicine." When I was a resident in the 80s, in the middle of the AIDS epidemic, we said, "He who knows," of course we said he then, he or she who knows AIDS knows all of medicine. Would you say that he or she who knows COVID knows all of medicine? Is it that sort of multifaceted a clinical and pathophysiological problem?
I was surprised by, I would say if one could know like COVID-19, then they could know all of like medicine and society. But I think the big thing for me was realizing that COVID-19 intersected with so many aspects of medicine and society that I could never even like start to fathom. I went on I called it a little like hypomanic writing binge during COVID, but it covered everything. I wrote a piece for the LA Times about how romantic relationships were affected because I was quarantined with my partner, and I was like, all of these dynamics I'd never even thought of forcing couples into a space, and how do they survive that, and what does that mean for their relationships? I wrote another piece about how guns were labeled to be an essential business during COVID-19 at the same time that we were seeing a mental health crisis, and likely putting society at risk of having a lot of suicide deaths, since death by suicide with a gun is the most likely, like the most fatal method of suicide. Or another piece about hydroxychloroquine having psychiatric side effects. It turned out there was a press release from the FBI showing that now that kids were more at home during COVID-19 and online, there was a higher risk of online sexual predation. So I wrote a piece about how parents could talk to their kids to try and protect them from that. But it seems like just from every angle, there's something scary and kind of awful going on. And I think it's helped me kind of realize that even one very small topic intersects so many things in society.
Mm-hmm. Yeah, I loved your addendum to the, to the old saying, not only knows all of medicine, but all of society, which is also perhaps why we've seen so much writing from clinicians, just kind of keeping your head down, doing your work, and seeing one patient at a time. I think for many of us, didn't, felt confining, didn't feel adequate. You have been amazingly prolific, Jack, and all of you under these circumstances. Sarah, have we got anything in the chat, or have we got a shy people out in TV land?
We do have a shy group tonight, but I think your questions have been terrific.
Okay. Well, we've actually reached the 7 o'clock hour, and we want to thank everyone who watched, and again, all of our sponsors and hosts and participants. I will just say, personally, you lift my spirits during this very dispiriting time, and I thank you for that. And bye, everyone.
Good night.
And those of you who are leaving, don't be strangers. Bye, everyone.